One of the major problems about information was signposting. How do you get into the system? What is your point of access of getting into the system? And once you're in the system, is there clarity about how you flow through the system? And again, I get back to joined up thinking. Services should be integrated. It's a buzzword now in the health service, vertical integration. Which means that you go to see your GP about something, perhaps that could be avoidable, perhaps you just need to see the district nurse, but that point of contact should be integrated, if you need it, right through your care pathway, so that if you're unlucky enough to need, at the extreme, say an operation, you know where you have been going, or potentially going, right from the start. Clinical information should be made available to patients, and it should be easily understandable, and most importantly, it needs to be shared between organisations. There was a question at the back at the beginning of the presentation about care records. Clearly, it would be inappropriate to give people massive sets of notes. Some of my patients have got 5 sets of notes that big. But they mustn't get lost. We need IT to be able to do these things for us for the future. And I think that was one of the big things that came out of all of the groups. Care should also be planned and delivered in a more holistic way than it is at the moment. There's a lot of fragmentation that is occurring. And I think the driver, as the acute care pathway group found, should be, can we keep the patient at home? And if we can't, when the patient's ready to go home again, have we done everything we can to ensure independence of that person? Now, I won't go into all the details because they're outside and they're in the report, but that was very much the flavour of a seamless service between community, primary care, secondary care, and even without of the SHA into tertiary care. Many people from South East Coast go to London for some of their tertiary requirements, and we need to integrate all of that. And finally, as I've already alluded to, we need full integration of social care packages into all of that. No matter how good your hospital is when you have a stroke, no matter how good the ambulance service is that takes you there timely, warning the hospital that there's a stroke on the way, that the CT scanner is all warmed up, ready for your diagnosis, that the thrombolysis is all ready to be given, that hospital will come to a grinding halt without integration of how you will then flow through the system, receiving your rehabilitation and physiotherapy and getting back into the community again. So we have to think as to how we're going to join all of those things up. At the present time, particularly in South East Coast, we have a very highly skilled workforce, but nothing is perfect, and it could be better still. Our workforce skills need to be maintained. They need to be up to date, taking account of the latest technology so that patients can always receive very high quality care. This particularly came out of the paediatric group, maternity group, and care of the dying. If you're going to deliver that care, there must be evidence that you are capable of doing that. And for the terminal care group, what they wanted to see was evidence that both in the community and in the acute trust, people had been trained and had appropriate qualifications to deliver that care. And you will find the same flavour running through paediatrics and maternity. I've already touched upon the accessibility of services, that they should be easily entered into. Better home care will improve patients' experience and avoid admissions, allowing the unfortunate people who do need to go further in their journey to get a faster and more efficient service. If you don't put all your money up front to treat people with unnecessarily high-tech things, you can develop even better technologies for the small group that go on to need even greater quality and high-end technology care. And I suppose that's best illustrated by patient groups being willing to bypass hospitals to go to centres of excellence, providing they can be reassured that they've still got a good quality hospital near them for what they need, that they've still got good quality GPs in their neighbourhood, but they are willing to travel further for high technology, providing that technology is being used in the correct way, and we're back to the skilled workforce then. Primary care, people were pretty satisfied with primary care, but as you've heard on the news, they would always like more, and so they want more accessibility into primary care. But it isn't that part of the journey which is the end to it. Once they've got into primary care, they want easier access for whatever primary care is telling them that they need. And I think a classic illustration of that was one of the suggestions that came out of the mental health group. You've got fantastic targets for cancer, and there's evidence that we're beginning to do that. Well, let's have some of those things being developed for mental health. Mental health is no different to cancer. It's somebody in dire need, so let's get ourselves into the position where we can offer that quickly and safely. How do we actually do this? As I said, today is a start, and as many people have called it, this is the end of the beginning, but it is the start of a very big journey which requires wide clinical engagement, and I use the word clinical in the very broadest of terms. I'm hopeful that the care pathway groups will maintain their input and actually gather momentum as we go forward. Many people have put an enormous amount of effort in and will have reached the end for what they're willing to do, but we should be stimulating interest from all clinicians across the patch now, and so we have the ideal opportunity that the care pathway groups can be extended and rolled out much more broadly than they are now. And I'm sorry to keep coming back to it, we need a broader consensus with our other stakeholders, particularly social services, and with patients themselves. Patients have got still a lot to tell us. Patients have also got a lot to learn as well, but they can only learn if we give them the information that they can digest and use. So, there are two ways of looking at where we go now. One is a massive task, and shrug your shoulders and perhaps don't get involved with it. The other is, well, we've got an exciting summer ahead of us. Let's get down to it and harness all of those things.